say hi. Thank you guys for taking time out of your schedules to join us for our first virtual town hall of 2022. We have various members of our CF care team at Children's on the call, obviously various parents, people associated with the CF community on the call. I want to thank Carson and Mike for helping to host this through the Rocky Mountain chapter. I'm going to have you go, Carson, to the next slide. We tried to put together an all-star cast for you guys tonight. Sort of our weakest lineup hitter is going to start off. I'm going to provide a few clinical updates here at Children's, and then really, the big hitters are going to be following up. So Edith Semanic's going to present some research updates. Judy Fulton, who is one of our nutritionists and our program coordinator here at Children's, is going to provide programmatic updates. We're going to then turn it over to Mike and Carson for any Rocky Mountain chapter updates. Dr. Emily Muther, one of our psychologists as part of our team, is going to provide mental health and supportive updates. And then it's going to lead into, our featured speaker, Dr. Sam Monson, who is, we're thrilled to have join us tonight and speak about her experiences as a person with CF, as a mom, as a professional, as a psychologist. So just has so much to offer us tonight. So thrilled to have Sam joining us, and we'll certainly have time for questions and answers. So I'll have you, Carson, go to the next slide. And we're going to start with just a few things clinically. And the next 3 slides are data from the United States Cystic Fibrosis Foundation Patient Registry. So these are things that most of you guys who come to accredited CF centers like Children's Hospital Colorado, most of you consent to have data shared with the National Registry. And it's been, an invaluable tool for us to learn about outcomes in people with CF and how to improve outcomes. And so I'm going to share a few graphs here. This first one is looking at nutritional outcomes. So the figure on your left is looking at median nutritional outcomes, so things like BMI, height, and weight. It looks like Carson's trying to play with the pointer there. She's doing a nice job. But looking at changes in BMI, height, and weight from the year 2000, so on the far left, to the year 2020. So the last year we have data is 2020. The data for 2021, we just finally imported in February of this year. So through 2021, it'll come out later this year, but this is through 2020. And you can see over these 20 years, when we knew that things were getting better in cystic fibrosis, well, they were clearly getting better from a growth perspective. You see improvements in all of those weight, height, and BMI. And so even the fact that height's getting better, argued that people with CF were stunted. They didn't grow to their full potential. And so that's something that's, we want to continue and improve. BMI, you can see, is now really crossed the 50th percentile for children with cystic fibrosis. Now, that's good, but we're facing another issue that I'm going to highlight now on the figure on the right, which is, so why do we push better nutritional outcomes? Why do we want somebody to weigh a little bit more for their weight for length or their BMI to be at or above the 50th percentile? It's because of this figure, on the right, where it's looking at the relationship between your lung function. The main measurement of lung function we use is called forced expiratory volume in 1 second, or FEV1 percent predicted, looking at BMI percentile. And what you can see is you cross the different sort of BMI percentiles, a higher BMI, it's associated with better lung function or better FEV1. And that black line is at the 50th percentile for BMI. So with the BMI at the 50th percentile, on average, the FEV1 is close to 100% predicted. Now, in general, 80% and above is considered normal for lung function. but we really, we aim for people to be at or above 100% predictive for lung function. And so there's that relationship that it doesn't, as you get to higher and higher BMIs, you really get minimal incremental benefit in lung function. So we wouldn't necessarily want somebody to be at a higher BMI from a lung function perspective. There's really probably not much benefit there, but we do want people to have really, what we don't know what their growth would have been without cystic fibrosis, but it's why we often target a weight for length or a BMI at the 50th percentile. I'm going to have you go to the next slide, Carson. So this next one is looking at lung function, which I just mentioned, FEV1% predicted. And we're looking at it in different cohorts. So people with CF who were born between 1991 to 1995 in the red line, above that, 1996 to 2000. One of the uppermost lines in brown is 2006 to 2010. And the most recent data that we actually get lung function measurements is in a birth cohort from 2011 to 2015. And you can see on the sort of x-axis, the horizontal thing, it's from ages 6 to 29 years of age. While we start to try to measure lung function at ages 4 and 5, we really start to get reliable measurements closer to 6 years of age. So that's why the data starts like this. And again, this figure shows something similar to what we were seeing with the nutrition, is that for each successive birth cohort, lung function has gotten better. And it's really improved about 10 percentage points between the 1991 to 95 birth cohort to the 2006-2010 birth cohort. Now, another thing I want to point out is, despite those improvements in lung function, in adolescent years, it looks like each of the lines is going down, that lung function is going down. And that has been one of the unfortunate things of CF. Even though treatments have gotten better and we're doing a lot of things better in ways, we still couldn't prevent lung function from falling in people with cystic fibrosis. And that's really until this last year that with the approval of Trikafta, we're seeing with the red line, the purple line, the orange line, the brown line, that all of a sudden lung function goes up at the very end of those lines. And that's again with the approval of Trikafta that was approved initially down to 12 years of age in the fall of 2019. Last year was approved down to 6 years of age, and we're hopeful that sometime later this year, it will be approved down to 2 years of age. So this is really the first time we're seeing this inflection or this improvement in lung function, that we hope that we don't see the same decline in lung function that we historically did before it. Next slide, please, Carson. And this one's looking at the different airway infections. So when you guys come into clinic, we do cultures. We either swab the throat of your children or we have them cough up mucus into a cup, and we culture for particular bacteria that we know that are in airways of people with cystic fibrosis and can cause problems. And so that the bacteria that we see most commonly in people with cystic fibrosis, which is the line in green, sort of at the top, is Staph aureus, that anywhere from 60 to 80% of people with CF at these various ages are infected with Staph aureus. So that's the most common. I can tell you this graph has changed significantly during my career. During my career, the line that's in blue, sort of the light blue, the ocean-looking blue, is Pseudomonas aeruginosa. That used to be the most common bacteria, starting in adolescent years. So starting at 11 to 17 years of age, that was the most common bacteria, and it's no longer. It becomes the predominant bacteria now in adulthood. And part of that is, that we have good ways to survey for the bacteria. We have good ways to treat the bacteria. And in part, Pseudomonas is one that's very opportunistic in CF. We don't tend to see Pseudomonas in people without cystic fibrosis. We see it in people with CF. There's other conditions, people who are immune compromised, people who face cancer and are very sick in the hospital. who can get Pseudomonas, but most people who are otherwise healthy don't generally get Pseudomonas. Staph aureus, on the other hand, is actually a common bacteria among all of us. If we swabbed all of our throats on this call, many of us actually would have Staph aureus in our upper airways, in our nose, in the back of our throats. And so that's more common. It's harder to get rid of. It's a bacteria that actually likes our airways, likes our skin. So it's really a harder one to get rid of. But we've really been successful in being able to clear Pseudomonas, or at least stave off this chronic infection in many people. So that's been a changing story as well here in CF. I'm going to have you go to the next slide, Carson. So the next couple slides I want to show you are why we make you guys come into clinic. After a year of age, we recommend you guys come in every 3 months to clinic visits. And these next two slides get at this. This was data from what was called the Epidemiologic study of cystic fibrosis. This was a registry-based study following the approval of Pulmozyme. I don't know if there's people on the call that remember that Pulmozyme was the first FDA-approved treatment for people with cystic fibrosis in the mid-1990s, 1996 actually. And as part of their regulatory approval to the FDA, they wanted to do what's called a phase 4 study to look at people on Pulmozyme therapy and other therapies in cystic fibrosis. And these were data, from that registry where they looked at people who had a good lung function versus people who had a lower lung function to see what was different about them. And one of the things that was different about them, the people who had better lung function, is that they were seen in clinic more frequently, they underwent lung function testing more frequently, and they underwent cultures more regularly. So those are the people sort of in the orange bars, versus the people with lower lung function. They tended to get fewer lung function measurements, fewer cultures performed. And again, those are related to just simply coming to clinic, because that's what we do in clinic visits objectively. We regularly perform lung function if you're 6 years of age and older, and we regularly perform cultures. And so the argument is that more aggressive monitoring leads to more aggressive treatment. That's one data. Next slide, Carson. And then this was another one where the CF Foundation did a benchmarking project where they really looked at the high-performing sites across the country, the sites that have good lung function, sites who have good nutritional outcomes, to see what things were in place that led to these better clinical outcomes. And there were a variety of things like having good leadership, the attitudes of the team members towards having high expectations for best possible outcomes. There was patient and family engagement. It's why we want to partner with you guys in ways to improve care at our center, different quality improvement projects at those centers. But what we've sort of highlighted in yellow is, the practice pattern itself. Is that a couple that really stood out is that, again, more frequent clinic visits were associated with better clinical outcomes, because again, it was a way to identify health concerns as they're happening, as they're emerging, so we can intervene more quickly. And that, having these regular patient visits with the full CF multidisciplinary care team, to have the expertise of our respiratory therapists, our nutritionists, our physical therapists, our psychologists, really having that full multidisciplinary care team approach is also what leads to better outcomes. I'm going to have you go to the next slide, Carson. And so, clinic, we want you guys to come to clinic, but again, things have been challenging in the last couple of years. So the pandemic certainly hastened our model to offer telehealth visits that most of us think work pretty darn well. That it's a way to still stay engaged, to understand if there are symptoms or concerns or problems that we need to think about and help look into. We can do things that we would ordinarily do in clinic, including weight measurements, height measurements, lung function testing, where we can get you guys portable handheld spirometer devices to measure lung function. We can send you respiratory kits to collect samples at home, ship them into via FedEx that comes to our microbiology laboratory. So all the things that we could do in a clinic visit here on site can also be done in telehealth. So I certainly encourage those of you who are still, cautious and not totally enthusiastic about coming into clinic regularly, that we can still do things regularly via telehealth. But we certainly offer in-person visits like we always have. Here at the main campus at Children's Hospital Colorado in Aurora, we have the two monthly clinics at the North Campus in Broomfield, the South Campus in Highlands Ranch. We have a CF clinic in Colorado Springs at the Briargate location. And then one of our pulmonologists practices it in Grand Junction. And we do telehealth in combination with in-person visits in Grand Junction with our provider out there. So two great options for clinic. Next slide, please. Just wanted to highlight a couple changes among the care team. First, in terms of changing CF providers, many of you guys know Ruth DeVogue, who is one of our longstanding nurse practitioners. Ruth retired last July. We are all jealous of Ruth and excited for her at the same time. In this last year, Trisha Lenhart Pendergrass, who just completed her fellowship last year. She was doing a transition year as an instructor with our group, completing her research with Jerry Nick at the Adult CF program at National Jewish. She's been doing CF with our care team, but she's accepted a faculty position at the University of California, San Diego to continue CF clinical and care and CF research out there. So we just recently hired a new pediatric nurse practitioner, Heather Moore, who's actually been a long-standing member of our Breathing Institute here at Children's for well over 10 years. Heather's had a long-standing passion for CF, and we are tremendously excited for her to join our team. She will be shadowing some of us in clinics over the next few months, and then starting later this summer, she will be having her own CF clinic. So that's from a provider perspective. Next slide, Carson. And then a couple other team members to make mention of. Courtney Lynn, one of our psychologists, who's partnered with Dr. Muther, who's partnered with Abby Good on some of the different focus groups. Courtney, unfortunately, will be leaving us this spring and summer. She's been a tremendous resource for our program. Now, she will still be practicing here in the Denver area, so we still may use Courtney for some of our children who need outpatient mental health therapy. But at least on a team perspective here at Children's, we're going to be hiring Emma Lyons. Emma's been doing a fellowship under the tutelage of Courtney and Dr. Emily Muther for the last year. She will complete her training later this summer and will be joining our team. One of our social workers, Heather Torres, recently had a baby, decided returning to work wasn't what she wanted at this point in time. So I said she will be replaced by a player to be named, should be very shortly. All right, next slide. Let's see where we are. And from there, I'm going to turn it over to Edith. Edith, you're going to talk about research efforts and research team.
Yes, so I'm going to talk pretty briefly about research. There's a lot going on, so please, if you have specific questions, feel free to ask. I want to talk a little bit. We have had some changes also on our research team. So this is our group now of research coordinators. Just to remind everybody, our research coordinators are people that work with our team who are really specifically trained in research. They're typically the people that you will meet in clinic or by phone or MyChart who will approach you about participating in a study. Usually they come to one of the providers, to talk first, and we decide, if it might be a good fit for you. They schedule your research visits. They're there with you during them. They'll go through all the procedures and all the informed consent to make sure that you understand it, that you and your child want to participate. And they do most of the procedures in the research. So we've had several coordinators who've been with us for quite a while. So Mary Cross and Dana Coyle. Ali Keck has joined us maybe about a year ago and has been part of our group. We have two coordinators, Chris Hoveter and Eileen Finley, who are diabetes specific for CF-related diabetes. And then we have two new coordinators, Ariane Ganano and Anna Duong, who are both joined us in the past few months. So we're really excited to have them. And then Carissa Valente, you may not meet her, but she works a lot behind the scenes on our regulatory and does a lot of training and support for our coordinators. You can go forward. Sorry, I'm trying to forward myself. And then these are study investigators. So these are generally people you know from the clinic. So myself, Scott, Stacy Martiniano, Jordana Hoppy, we all participate in research. Emily Muther is one of our psychologists again. She does a lot of research on mental health and improving patient outcomes and quality of life. Heather Moore, who Scott just mentioned, who's going to be our new advanced practice, is going to be probably seeing some kids during research visits, so you may see her there. And then Christine Chan is our endocrinologist who leads our CF research, diabetes research. So our jobs as study investigators are really to be responsible for oversight of the whole study. We help design it. We help make sure all the regulatory things are in place. Really, like our #1 priority is participant safety. So we want to make sure whatever you're doing in the study, we are following all the safety guidelines, tracking very carefully to make sure that things are going well for you and your child. We want to make sure the study's right for you. And then of course, we want to look at the results and see what they can tell us about how better to treat people who have cystic fibrosis. The next slide. I'm going to just highlight 2 examples of studies that we have right now. We have some studies that are drug studies. So those are like the ones with Vertex drugs. And then we have a lot of other studies that are looking at other things in CF that are also very important to how people with CF live and are managed. So the impact breath study is one that we are looking at ways to detect Pseudomonas. I think a lot of people know Pseudomonas aeruginosa is a really important bacteria in people with CF because it can cause a lot of problems in the lungs with more infection and scarring over time. And so it's really important to be able to detect this. And right now we use cultures from either a throat culture or if you can cough up mucus from sputum. With Trikafta and other treatments that have just made people healthier, less and less people are able to cough up mucus, which is great. It means people are healthier, but it makes it harder to find these infections. And we know that people, even when they're on the modulators, still can get lung infections. So it's really important to monitor. So this study is looking at another way of detecting using a breath sample. So you might be approached about this. And then the next slide. And then this is one of our CF diabetes studies with Dr. Chan. And this is really looking at how people with CF use sugar and looking at other ways to measure problems with sugar using the oral glucose tolerance test. One thing that's nice about this study is that it counts towards your oral glucose tolerance test that we recommend annually starting at age 10. So if you are part of this study, you get this done for the study and you don't need to do it outside of this. So that's another one you may hear about. Next slide. And then just a quick update on the modulators. So things are progressing. And the goal now is really to get the younger children access to Trikafta. And we are currently doing a study of children 2 to 5 years of age who have either 1 or 2 F508del mutations. This is a phase 3 study. It's fully enrolled and ongoing, and we are really hopeful that the results will be available soon. And then this would go then to the FDA for review. And then the hope is that the drug will then be approved for all children who have this mutation, at least 1 F508, to be able to take Trikafta. There's another study going on right now that right now is age 12 and older, but is very close to going down to younger age groups, which is a medication very similar to Trikafta, but if approved, it would be a once a day dosing. We don't know if it would work better than Trikafta. It may work the same, or it may work a little bit better. Hopefully it works at least as well. But the goal would be to have a once a day treatment option. And then the next slide. And then this is just an idea, again, I'm not going to talk, this is my last slide. I'm not going to talk about all the research that's happening, because it would take the whole time and more, but there are a lot of things happening in research in a whole variety of areas. So, and this is how the foundation kind of breaks it down. So looking at things that restore or improve how the CF protein called CFTR works. And those are things like the modulators, but there are also medications that could potentially help people regardless of their mutation. So, and these are in very early studies right now. There's not something that I think is going to be available really soon on the horizon, but we are really hopeful that these will be good therapies for people regardless of their genetic mutations to help improve how they're doing. There's also studies on improving mucus clearance, medications to treat inflammation, and new medicines to treat infection. We know infection is probably not going to go away. And so it's still very important to be able to treat infection in all people with CF. And then nutritional interventions to help. And then I just want to highlight two websites. So the first one is something called Community Voice, and you can go to this on the cff.org website. And this is a way that you can get involved in giving your input, and not just for research. There's it's around clinical care, and it's for you. It can be adults with CF, and the whole community really to get input. And there is a section on research, and so you can give input on things that what you think is important for us to be studying in CF. And so really getting your voice out there is really critical for us. And I will say we use this information for really all of our studies now. So as we're starting to develop studies, we're looking and talking with people in Community Voice to get their input. So it's really important and changes what we do. And then the last thing is there's just a resource about clinical trials. So you can look on the website. You can look and see if there's trials that your child might be eligible for. Just get a sense of what might be out there as they get older. So that's a really great resource also. And that's my last slide.
Okay, so I'm going to talk about some initiatives and programs that we've been doing over the past year. So the first is the Xoc Survey, which stands for Experience of Care Survey. This is a survey that was developed by the CF Foundation that is used at all the CF centers across the US. And when you come into clinic, you should get a phone message, text message, or an email regarding this survey. And the reason why we're doing this is that we want to make sure things have changed over the last couple years, and we want to make sure our inpatient visits and our telehealth visits and our satellite visits, that you're getting the quality of care that we want, the same quality of care at all these visits. We also want to hear what's working and what isn't working. And we want to make sure you're seeing all the team members that you want to see. And most importantly, we want to make sure that you walk away from your clinic visit with your questions being answered, and you're not walking away with more questions. So again, by collecting this information from this survey, it can help us improve our care process. And what we do with these survey results, myself and a parent partner, we review them and then we present them to our CF team so we can then work on process improvement. Next slide, please. So again, for you in the audience, what we need you to do after a clinic visit, when you get this text message, please click on it, take the 10 minutes to complete the survey. And most importantly, please make sure that you update our contact information so we have the correct cell numbers and updated email addresses for everybody so we can communicate with you and pass on this survey. Next slide, please. Another program that we've been working with is called CF RISE. RISE stands for Responsibility, Independence, Self-Care, and Education. This is an education program that was developed by a team of CF experts for young adults starting at 16 to 25 down to 10 to 15 years of age. We are currently doing this program at our center starting at age 13. Jill, Katie, and Ruth, before she retired, they worked effortlessly getting us involved in this program and trained in this program. And again, the goal is to help have our teenagers gain the knowledge that they need to be more independent and be prepared for transition from pediatric to adult care. This program has different responsibility checklists and knowledge assessments that are given to the kids during their clinic visits. The topics vary from nutrition, respiratory, to mental health. And then each of the individual team members will review and discuss the knowledge results and sometimes even set goals with your teenagers to help them before the next clinic visit. Next slide. So transitioning to the adult CF program at National Jewish Health. This has been a big incentive in the past year that Elisa, our social worker, has been working on effortlessly. And this program, again, is taking the pediatric program at Children's, the adult program at National Jewish, and working in the virtual environment that we've learned to enjoy since the pandemic. And we are doing virtual transition clinics. First, we meet with the medical team virtually, discuss teenagers, young adults who are getting ready to transition. And then in a separate clinic, we actually have these young adults from our PEDS clinic scheduled to meet virtually with the team over at National Jewish. So it's just kind of a nice way to expose them to the new team that they're going to be working with. They can discuss what to expect, identify goals, talk about different initial needs that they might have during the up and coming clinic visit. And then most importantly, we're actually scheduling in-person visits. And over the past year, we have transitioned through this program over 15 of our young adults. Okay, next slide. So this is my last slide, and I just wanted to give a shout out because we are looking for parent partners, and parent partners are volunteers. And yes, we need your help. We need the family perspective of working, in our CF clinic and helping us to try to improve our quality and process improvement with our patients. We've had several different parent partners and volunteers that have helped us with research studies. I mentioned the Experience of Care survey that we've had a parent partner help us with. We've had parent partners review educational handouts and tools that we've used in our clinics, and we also have used them in different advisory committee levels. So again, if there's anybody out there that you would like to discuss, volunteering at any level, please let us know when you come to clinic. So we would love to discuss more. And next slide.
Okay, I think that might actually be me. I'm not sure if Mike is able to join in. I know he is driving right now.
Yeah, I'm here as well. Not on video, but I'm here.
Okay.
I'll let you take it, person.
Okay. So Mike and I are with the local CF Foundation chapter, and we're so excited to see so many names on here and that we know, and just wanted to share a few updates that we are looking forward to this year for our events and finally being able to be back in person and seeing everyone together. So coming up this weekend is Denver Great Strides, and that'll be at Sloan's Lake Park beginning at 9 a.m. And I know there are a lot of you on here who are already registered to attend. If you haven't had the chance to sign up yet, you can still join us Saturday at 9 a.m. and then the walk begins at 10 a.m. So we We'd love for you to come. If you can't make it this weekend in Denver, next weekend we have the Colorado Springs Great Strides at America the Beautiful Park. And then in June, we'll have the Denver CF Climb that we are hosting again at Broncos Stadium. Then our summer soiree is coming up on August 20th, and that will be a mix or a combination of our finest event and our chef's event. So it should be a really fun celebration to honor the finest classes of the last 2 years, and then also start bringing back some chef partner restaurants for some delicious tastings. And then in September, we have the CF Extreme Hike in Vail, which is also a wonderful weekend. And then we are going to wrap it up with our Breath of Life Gala on November 12th. And that will be at Vehicleville in Parker. So we hope to see you at some of these events. And if you have any questions, please reach out to us. We're here to help and support as well. And then just also wanted to bring up a couple more resources through the foundation, which Compass can help with any sort of insurance or other issues that might arise. So please reach out to them if you have any questions. And then also CF Peer Connect. And this is an opportunity to partner or be paired with someone who is in kind of a similar experience and just someone to relate to and talk about what's going on. So these are just 2 programs that we wanted to highlight this evening as well. But if you have any questions or need anything, feel free to email us or drop it in the chat and we are happy to answer. So
yeah, and just real quick, Carson, with the Peer Connect, one of the questions that have come up was connecting youth. Unfortunately, the CF Peer Connect program, I think, is only able to do mentoring, mentee connections for ages 16 and up. Because unfortunately, just with liability and age and such, that we are not able to do Peer Connect partnerships with youth 16 or 15 or younger. But if anyone is 16 or over, we do have those for people with CF to connect to each other. We also have Peer Connect has started doing connecting families. And so parents, there is a parent Peer Connect network that if you need support or just want support or even want to be a mentor, you can sign up through the same Peer Connect channels.
perfect.
And yeah, like Carson said, if you guys ever have any questions or need anything, feel free to reach out to our chapter office.
Great, thank you guys. I think I'm up next and I really am excited to get us to our main event. So I'm hoping to do this quick, but I think having Sam here with us is a nice opportunity for us to talk about additional ways that as a care team, we're thinking about how to support not only your children, but you all as caregivers and other family members. And so one of the additional updates that we have, Judy shared a lot of programmatic updates that we've been working on. The Partnership Enhancement Program is another example. And so this is the PEP program. Abby Good, who's our physical therapist, hopefully all of you have met, is our PEP champion and really kind of taking the lead on helping our team be able to implement this program. And the PEP program is a program that's sponsored by the Cystic Fibrosis Foundation. Many of our care team members went through a specific training that focused on helping us be more aware of and improve our communication with the goal of helping to partner with you all, not only as it relates to kind of goals and things that you have, but even on the day-to-day kind of logistics of what our clinic visits look like, how the flow works, and how we're making sure that we're understanding your priorities and we can partner with you to make sure that clinic visits feel meaningful and as effective as possible. So you can see here that this is an example of one of our efforts that we are hoping to implement as a result of the PEP program. And this is a sheet that you all will start to see in clinic. I'm not sure if it's going to be on a whiteboard or an actual physical piece of paper, but this has the list of all the different disciplines and team members that are on our team. And our hope and plan is to be able to let you all know in advance when you come to clinic and get in your room who's planning and hoping to check in with you that particular clinic visit, and then give you all a chance to let us know if there are other people that you were hoping to meet with, or any additional questions or concerns or potential time constraints that you might have where we can regroup and come up with a new game plan for clinic. But you'll start to see this soon. And again, the purpose is to be able to really make sure that we're checking in and communicating with you all about what's important beyond our goals for what we want to check in on in clinic. Next slide. And then I wanted to just briefly share a little bit about our mental health screening. Many of you who have adolescents who are 12 and older have hopefully, very likely, been aware that they've participated in our mental health screening. We began in the last year or so to also start screening some of our all of our school age children as well. But this effort to screen our adolescents is something that we've been doing really since 2015. And we've tried to become more effective and efficient at doing this. And so I just wanted you all to see a snapshot of what our screening results look like. You can see that in the past year, we screened about 92% of our patients. Again, these are patients who are 12 and older in our center. And just about half of those patients, a little over half of those patients, did not report any elevated symptoms on those screeners. So we used two screeners, one for depression, which is the PHQ-9, and one for anxiety, which is the GAD-7. And those screeners, just to mention, are really not necessarily diagnostic. So they don't tell us if your child meets criteria for an anxiety disorder or a depressive disorder, but really let us know that there may be some stressors going on at different levels or at different ranges. And the hope is that we can intervene and provide support, make recommendations, and be able to also do brief interventions to help address those symptoms. So while 53% of our patients who were screened in the past year did not endorse any elevated symptoms, we had almost 50% of our patients, 47%, who did endorse elevated symptoms. And so then you can see further below that, if I had a pointer, I would show you that about 25% of those patients who were elevated, thank you, Carson, were elevated on the depression screener. And just to kind of give you a context, when we think about depression in the general population in children 12 and older, we find that it's about 4 to 8%. And so you can see here that, that for kids with CF, they are about 2 to 3 times higher. And that extends also to anxiety. So anxiety is a little bit more prevalent in our population. This also matches, this isn't just for our care center. We've found these results extend to the CF community nationally and even internationally. But about 40% of our patients who were elevated on anxiety. In the general population, the prevalence of anxiety in childhood and adolescence is close to 10%. So this really is about 4 times higher than the general population. And then about 35% of our patients were elevated for both anxiety and depression. And so again, this is really meant to be able to help us and you all as caregivers and your children be able to be better aware and have the support and tools and resources to be able to address some of these stressors that may be contributing to these symptoms. Next slide. And then I just wanted to briefly mention some of the other screening that we're doing, and we are tracking some of this information as well. So we're using the pediatric symptom checklist. Some of you who have children under 12 may have filled this out. This is a parent report of your child's symptoms and behaviors. It looks at things like internalizing, which would be more like anxiety, externalizing, which would be behavioral problems, concerns about tantrums or having a hard time regulating emotions. And then it also assesses for difficulty with attention. And so we're implementing that annually for kids 4 to 11. And then we've been rolling out the caregiver screening, both anxiety and depression for caregivers of all of our children in our CF center, as well as doing postnatal stress assessment or screening for our parents who have babies in the first year of life with CF. And that's really a partnership with our social workers. And again, with the same goal of really making sure we can proactively check in on how you all are doing, provide support. We know there's a long list of stressors that exist. just in having children, but certainly having kids and managing the day-to-day with CF. Next slide. And this is just a visual to show kind of our overall goal when we think about embedding and integrating mental health into our CF center, that really the majority of the support that we can provide is proactive and prevention, that we get to know your kids and you as families. We get to be involved to check in on things that are going well. We also can help you think about how to reduce potential stressors or anticipate periods of time that may be more stressful, life transitions, talk about things that can help with that. And that we can ultimately help prevent some of those additional concerns that may come up in adolescence or later on in life. With a smaller portion of our time being focused on early intervention. So that's things like when we do screening, if your child may be elevated, talking about recommendations, giving some information about how can we help manage anxiety, what are some evidence-based interventions that can help with reducing anxiety or reducing depression. And then again, the smallest portion of our time hopefully is spent providing those mental health interventions. And we are available. I know Scott mentioned, sadly, we're having a bit of a transition in our psychosocial team with Courtney leaving, but we're lucky to be able to have Emma on. And part of our role, in addition to being in clinic and checking in with you all and hearing what's going well, is also to be available outside of clinic as well. So that's part of our model. I think I have a couple more slides and a dog that's about to bark in the background, I believe. So one of the ways that we have really thought about how can we be more supportive and provide some of those kind of early intervention supports to you all is through therapy groups. And there have been several of these that have happened over the years, which has really been the effort of Courtney Lynn, our psychologist, and then certainly Abby Good partnered to do a couple of these groups as well. Some of you may have participated in these, but here are a couple examples. The Unite to Thrive group was a group that was targeted for adolescents, so in that adolescent teenage range, that included interventions like yoga, Pilates, HIIT, strength training, breathing, mindfulness, acceptance, and diffusion. I think we joked that many of us, probably all of us, could use this and would love to go through this group with Abby and Courtney, but this was really meant to think about wellness and focus on helping give tools to our adolescent patients for managing stress. And then a parenting through play group. Abby and Courtney and Emma, our psychologist, and our other psychology trainee have worked on this. I knew it was coming. And this is a group targeted for toddlers with their parents, really thinking about how can using play, how can parents use play to help reduce or improve some of these aspects for our patients. Next slide. Hi, Tico. And then lastly, we have a group that we've been doing for a little over a year, which we call CF COPE, and this is specifically for caregivers. It stands for Connecting with Other Parents' Experiences. I know some of you on tonight have gone through this group, and this is really meant to be a support for parents of babies with CF in the first year of life. And the goal, in addition to providing you with an opportunity to get support and meet other parents who have babies with CF, is also just being able to process some of the experiences, talk about things that you've learned as you've been managing the routine of getting adjusted to having CF. And so this is something we run. We try to run it twice a year, and so we reach out to families who have babies in that age range.